Good day, everyone. Praise be Jesus and Mary. In this video, we will going to discuss a case study about peptic ulcer disease. For the table of contents, the case study and introduction will be discussed by me. The pathophysiology and clinical presentation will be discussed by Pelonia, and relative information to the case will be discussed by Panes. For the case study, a 20-years old male visited clinic with complaints of an upper abdominal pain, heartburn, nausea, and sometimes vomiting. He was in usual state of health 5 days back when he started having epigastric pain. Pain aggravated at night after taking large meal. He was fond of fried and spicy food. He had a family history of peptic ulcer disease, and he denied cigarette smoking. For his past medical history, he was using Synflex naproxen to relieve pain from past 2 days, but no significant effect. Then he decided to consult a doctor. In his past medical history reveals that absence of any disease in the patient, and for the family history, patient's father had a history of peptic ulcer disease. In his general examination, his weight is 58 kilograms, his height is 5 feet and 8 inches, his BMI is 19.44 kilogram per meter squared, temperature is 98 degrees Fahrenheit, and his blood pressure is 120 over 70 mmHg. For the introduction, peptic ulcer disease is an erosion or lesion in the lining of the digestive tract. It interferes with the integrity of gastrointestinal mucosal layer within esophagus, stomach, and proximal part of small intestine called duodenum. Peptic ulcer disease is becoming a common health problem and widely prevailing throughout the world. Peptic ulcer disease affects about 4 million people annually in the whole world. About 10 to 20% of patients lead towards complications. Prevalence of H. pylori is more common in childhood and middle-aged populations. It is considered to be transmitted by oral ingestion of the bacterium. NSAIDs-induced ulcers are more common in elderly patients as they use analgesics more frequently. The mechanism by which NSAIDs may lead to and cause gastrointestinal complications are poorly understood. During early 20th century, it was believed that ulcers were caused due to smoking and stress. Later in 1994, it was concluded that there is strong link between ulcer and H. pylori. Apart from H. pylori, widespread use of NSAIDs is the major cause of gastrointestinal injury. Other factors responsible for disease includes eating too much spicy and fatty food, stress, drinking alcohol and coffee. Symptoms of peptic ulcer include epigastric pain, heartburn, nocturnal pain, nausea, postprandial pain, weight loss due to decreased appetite. If symptoms remain untreated, it may lead to complications like gastrointestinal bleeding, perforations, penetration, narrowing, and obstruction. When H. pylori and use of NSAIDs is present together, it increases the risk of bleeding.
For the pathophysiology, despite extensive research, the etiology of peptic ulcer disease remains unclear, given multiple processes that control acid and pepsin secretions and defense and repair of the gastroduodenal mucosa. It is likely that the cause of ulceration differs between individuals. Acid and pepsin appear to be necessary but not sufficient ingredients in the ulceration. In the ulcerative process, it is clear majority of gastric ulcers and a substantial number of duodenal ulcers do not have increased gastric acid secretion. So, the erosion is caused by the increased concentration or activity of acid pepsin or by decreased resistance of the mucosa. A damaged mucosa cannot secrete enough mucus to act as barrier against hydrochloric acid. So the use of nonsteroidal anti-inflammatory drugs, it inhibits the secretion of mucus that protects the mucosa. So the patient with duodenal ulcers secrete more acid than normal, whereas patient with gastric ulcers tends to secrete normal or decreased levels of acid. So the damage to the gas, gastro-duodenal mucosa results in decreased resistance to bacteria and thus the infection from Helicobacter pylori bacteria may occur. So next na. Next. So peptic ulcers are holes in the lining of the stomach and duodenum. It usually caused by a bacterial infection with Helicobacter pylori. The stomach produces hydrochloric acid and enzymes including pepsin that break down and digest food. A mucus layer coats the stomach and protects it from the acid. The prostaglandins also aid in protecting the lining. So when defenses are not performing their job properly, acid and pepsin eat away at the lining, forming an open sore called an ulcer. The Helicobacter pylori decreased the stomach's ability to produce mucus, making it more likely that acid will cause peptic ulcers, although Helicobacter pylori infections is found in many people, but it does not cause ulcer in all of them. Long-term use of nonsteroidal anti-inflammatory agents such as aspirin, naproxen, and ibuprofen can also cause peptic ulcers. Next, for the clinical presentation, the cause of peptic ulcer disease. The Helicobacter pylori infection and the use of nonsteroidal anti-inflammatory drugs are the predominant cause of peptic ulcer disease in the United States, accounting for 48 and 24% of cases, respectively. A variety of other infections and common comorbidities are associated with a greater risk of peptic ulcer disease. The cytomegalovirus, tuberculosis, Crohn's disease, hepatic cirrhosis, chronic renal failure, sarcoidosis, myeloproliferative disorder, or critical illness, surgery, or hypovolemia leading to splanchnic hypoperfusion may result in gastroduodenal erosions or ulcers. These may be silent or manifest with bleeding or perforation. So, smoking increases the risk of ulcer and recurrence and slow healing. The typical symptoms of peptic ulcer disease include episodic gnawing or burning epigastric pain, pain occurring 2 to 5 hours after meals or on an empty stomach, and nocturnal pain relieved by food intake, anti-acid or anti-secretory agents. So, a few tests may be done to help diagnose a peptic ulcer to identify the cause, detect the complication, and help determine appropriate treatment. So one or more Helicobacter pylori tests may be performed to detect infection. The stool antigen test, serologic test, and the urea breath test are recommended for the diagnosis of an Helicobacter pylori infection. For the patient, undergo different tests may be done to help the diagnosis of peptic ulcer. So one or more Helicobacter pylori tests may be performed to detect an infections. So the hemoglobin testing performed to check for anemia. The stool antigen test and urea breath test are recommended for diagnosis of an Helicobacter pylori infection and for the evaluation of the effectiveness of treatment. These tests are the most frequently performed tests because they are fast and non-invasive. Some tests involve serologic tests. It is an accepted method for detection of Helicobacter pylori. Sensitivity of this assay is generally in the range of 85 to 95% and the specificity in the range of 75 to 95%. So the diagnosis of the peptic ulcer, according to the provided information, the patient laboratory tests were done. So there were no signs of bleeding as hemoglobin values were normal, 13.5 grams per deciliter, and absence of blood in stools and vomiting. So the serological and urea breath test confirmed Helicobacter pylori positive infection in the patient with a sensitivity and specificity test greater than 95%. So, thus a result is defined as positive. For the treatment,
Hypersensitivity pneumonitis positive patients and reducing the risk of non-steroidal anti-inflammatory drugs induce ulcers and ulcer-related complications. Drug regimens containing antimicrobials such as clarithromycin, metronidazole, amoxicillin, and bismuth salts, and anti-secretory drugs such as the proton pump inhibitors or H2RAs are used to relieve ulcer symptoms, heal the ulcer, and eradicate HP infection. Successful eradication will alter the natural history of PUD and cure the disease. PPIs, H2RAs, and sucralfate are used to heal HP negative nonsteroidal anti-inflammatory drugs induce ulcers, but ulcers recurrence is likely high-risk patients if the non-steroidal anti-inflammatory drugs is continued prophylactic co-therapy with a PPI or misoprostol is used to decrease the risk of an ulcer and upper GI in patients. Taking non-selective non-steroidal anti-inflammatory drugs um, COX2 inhibitors are often used in place of a non-selective, non-steroidal anti-inflammatory drugs to reduce the risk of ulcers and complications. Patients with PUD should eliminate or reduce psychological stress, cigarette smoking, and the use of non-selective, non-steroidal anti-inflammatory drugs, including aspirin. Although there is no anti-ulcer diet, the patient should avoid foods and beverages, examples like spicy foods, caffeine, and alcohol, that cause dyspepsia or that ex- exacerbate ulcer symptoms. If possible, alternative agents such as acetaminophen or non-acetylated salicylate. Example is salsalate or COX2 inhibitors should be used for relief of pain. Treatment of Helicobacter pylori associated ulcers. The goal of HP drug therapy is eradication of the organism. Treatment should be effective, well tolerated, easy to comply with, and cost effective. HP regimens should have eradication cure rates of at least 80% based on intention to treat analysis or at least 90% based on per protocol analysis and should minimize the potential for antimicrobial resistance. 23 to 24, the use of a single antibiotic, bismuth salt, or anti-ulcer drug does not achieve this goal. However, Clarithromycin is the single most effective antibiotic. Two drug regimens that combine a PPI and either amoxicillin or clarithromycin have yield marginal and variable. Eradication rates in the United States and are not recommended. In addition, the use of only one antibiotic associated with a higher rate of antimicrobial resistance. The related information relevance to the case. PUD is a very common disorder that affects millions of people. When left untreated, it has significant morbidity. The majority of patients with PUD present to their primary caregiver, but others may present to the emergency department, urgent care clinic, or an outpatient clinic. So in this case, the patient suffered from peptic ulcer disease due to many reasons that include improper diet, spicy foods, late night meals, family history of ulcer disease, and stress that worsened ulcer symptoms. Patients was at the level where an H. pylori infection needs to be cured. According to research of symptoms of peptic ulcer are not treated, this may lead to complications like bleeding, perforations, narrowing and obstructions. Peptic ulcer patient can manage his symptoms by adhering medications. Combination of antibiotic therapy and PPIs are given in appropriate manner. Antibiotic resistance in some countries leads towards triple antibiotic therapy for better results. Lifestyle modifications along with adherence to medications are, important. Spicy and late night meals should be avoided. Due to poor dietary habits and sedentary lifestyle, patients faces difficulty in changing his routine. The patient is fond of spicy and fried food. Proper counseling improves the patient's disease education and motivates to follow the instructions. Once the diagnosis is made, the key is to educate the patient on lifestyle changes, which include discontinuation of smoking, abstaining from alcohol, and avoid consumptions of too many nonsteroidal anti-inflammatory drugs. The pharmacist should educate the patient on medication compliance to obtain symptom relief and a cure. For most patients with PUD who are treated with a triple regimen or PPI, outcomes are excellent, but recurrence of symptoms is not uncommon.